for patients who have a sense of dyspnea. Therefore, inspiratory capacity, if it's increased, and the FRC, which this decreases because of decrease in airway trapping, it produces a lot of relief from the sense of dyspnea and hyperinflation. And at the same time, because of decrease in airway trapping, the last bar which is shown, it decreases the slow vital capacity because of better lung emptying. Now, this is a graph which shows the rate of hospitalization due to COPD in patients who are on tiotropium versus those who are put on placebo, and one can see that after this is up to 350 days of treatment, there is a very significant improvement in the number of hospitalizations and exacerbations because of COPD. Now, one of the major modalities of treatment of inhaled drugs in the treatment of COPD is in combining one or more products, especially if one starts with the treatment of moderate, severe and very severe COPD. Usually we use 2 or 3 inhaled products for the treatment, inhaled agents for the treatment of moderate and severe COPD. Therefore, what is the role of combination therapy in COPD? This is a graph which shows the effect of the combination of ICS, that is inhaled corticosteroids, and LABA in as a combined effect if combined together in the treatment of COPD. Now, in the center one sees the normal effects of COPD on the lung, and inhaled corticosteroids, what they do is they decrease inflammation, increase neutrophil and reduce the neutrophil and CD8 lymphocytes, the elevated IL-8 and the TNF alpha, and also decrease the protease antiprotease imbalance. On the other side, LABAs inhibit the airway constriction, the smooth muscle contraction, increased cholinergic tone, the loss of the recoil, and the sensory nerve activation. Now, both have a additive effect, and it gives rise to decrease in the symptoms and decrease in the FEV1 and decrease in the number of exacerbations. This is another graph which shows the effect of combination of the synergistic interaction of beta 2 agonists with corticosteroids. Now, on the left one sees in yellow the corticosteroids which attaches to the receptor, the corticosteroid receptors, which is available in the cell, and on the right is the long acting beta agonist which attaches to the receptors which is available on the cell wall, the beta 2AR receptors. Now, when corticosteroids are used in combination with beta 2 agonist, it is seen that it helps one in the penetration of the corticosteroids in the nucleus, which is the area where they mainly have its effect, and also corticosteroids increase the sensitization of the beta 2 agonist receptors to beta 2 agonists, and therefore it gives rise to decreased airway tolerance, decreased acquired tolerance, and it also increased the anti-inflammatory effect. Now, this is a very beautiful study in which various parameters on the use of combined drugs was compared against single agents has been seen in a single study. On the first graph to the left on top is seen the effect of the combination of budesonide formoterol, and it shows the reduction in severe exacerbation in patients per hour per year. In blue is the effect with the use of only formoterol, and in the green is the effect of using budesonide, and in red is with the effect of Symbicort, which is the agent which is by Astra of budesonide and formoterol combination. Therefore, in all the graph you can see that the effect of combining a long acting beta agonist, that is formoterol in this case, with budesonide, which is an inhaled corticosteroid, has seen to be an additive effect which is seen in red. In the top left one sees the effect of decrease in severe exacerbations. On the top right one sees that the mild exacerbations are also reduced. On the bottom left one sees that the budesonide also reduces the use of oral corticosteroids in COPD, and in the bottom right it is seen that it reduces the symptoms of COPD within 1 week, and this reduction in the symptoms is more on using a combination of a LABA with a ICS. Now, this is in continuation with the same study. It is seen that the nighttime awakenings are also much better in use of a combination agent of LABA with the inhaled corticosteroid. Similarly, it increases the sense of the shortness of breath, and it also decreases the use of relief medications, that is the short acting beta 2 agonists. And lastly, the health related quality of life is also improved in the use of a combined LABA with the inhaled corticosteroid. Now, in this, one has tried to show the effect of combining salmeterol with theophylline. The lower graph is the effect of FEV1 change with only theophylline. In the middle in yellow is seen the effect of FEV1 increase with only salmeterol. But once salmeterol is combined with theophylline, one sees the graph in green, which shows more than an additive effect in the increase in FEV1. Now, the effect that we have seen in the previous study, that is with the effect of adding inhaled corticosteroid with a LABA. Here it is seen in the red is the placebo, in the green is the inhaled corticosteroid, and in the yellow one sees the effect of salmeterol. Now, using only salmeterol produces a effect of about 11% of the increase vis-a-vis the placebo, but once we combine salmeterol with LABA, one sees that the increase in FEV1 is by as much as 19%. This is another graph which shows the effect of addition of tiotropium, that is a long-acting anticholinergic, with a long-acting beta 2 agonist. Now, this is a very good combination which can be used in mild to moderate cases of COPDs, and in this chart you can see, in this bar diagram you can see that the mean change from the baseline in the trough FEV1 is also maximal, or it is additive if one uses anticholinergic long acting with a LABA. The change in the FEV1 in the peak effect is also more, and if you compare it completely over 12 to 24 hours is also higher in using a combination agent. Now, we have been talking a lot about inhaler agents. Now, it is our socially bound duty that to ensure that while we are using inhalers for the treatment of patients, we are also not harming the environment, and therefore there was a protocol which was people met together and decided, which is now known as the Montreal Protocol, and it was decided that by 2005 most of the CFC, that is the fluorocarbons agents, would be phased out. Now, most of the companies have started phasing them out, and they have shifted over to a different preparation which is called hydrofluoroalkane, which is used in the inhaler canisters. Some patients initially, once you give an inhaler with this hydrofluoroalkane, they find the difference and they might come and report to you. It might be seen that the taste differs with HFA compared to a CFC. Therefore, one must inform the patient. The spray volume is higher in a CFC preparation. Therefore, patients do not have that sense of satisfaction of having taken the inhaler, and the spray force is also lower in a HFA inhaler. Therefore, this is a thing on which the patients needs to be educated. Now, in addition, there is a mucolytic and antioxidant therapy. These are shown to be effective, and of these, N-acetylcysteine has been found to be most effective in this therapy. And alpha trypsin augmentation therapy is also used, but this has got a special place in patients with alpha 1 antitrypsin deficiency only. There is no role for leukotriene receptor antagonists or maintenance antibiotic therapy. Immunoregulators, vasodilators have a marginal effect because they have a what is called pulmonary steal syndrome, and therefore may be more harmful than useful. Respiratory stimulants also have no effect. Anabolic steroids have only a partial effect. Vaccinations are very useful, especially vaccinations against influenza and vaccinations against pneumococcal agents. There are few novel and therapeutic agents for COPD. These are short-acting agents which are berbuterol, aforterol, carmoterol. These are newer long-acting LABAs agents. There are few anticholinergics which are also in the pipeline. Second are the phosphodiesterase 4 inhibitors, which break down the CMP, the cyclic AMP, and therefore they could be useful. Leukotriene inhibitors, especially as leukotriene B4 is responsible, therefore they could be useful. Cytokine and chemokine inhibitors, TNF alpha inhibitors, and antiproteases. Long-term oxygen has been dealt on last time by Dr. Sen, therefore I will not discuss it further. This is used in patients with a SpO2 of less than 88% or with a PO2 of less than 55%, and between 55 and 60 only if they have polycythemia or they have cardiac failure. Now, pulmonary rehabilitation will also be dealt by Dr. Sen in one of the subsequent talks. Nutrition has a very important role, and especially loss of body mass is shown to be directly responsible with deleterious effects on mortality. Sleep is very important in COPD, and it is seen that sleep is associated with oxygen desaturation. Well, and one of the first
Dr. Bhattacharya, we have a caller with us.
Okay.
Hello.
Yeah.
Hello. Hello.
Hello.
Yeah, what's your name?
Sir, I have 3 questions to you, sir.
Yeah, please ask your questions. Hello.
Number 1 is just at the end of the session you can add to my questions.
Yeah, kindly ask.
Number 1 is when should we use a short-acting anticholinergic and
can I answer this?
Yeah, please.
And long-acting anticholinergics.
Short-acting
And
anticholinergics.
second question is in the sequel. And the second question is, and as a sequel of COPD, when a patient lands into pulmonary hypertension,
please go on.
How far the nitrates are indicated?
Okay, and what is your third question?
That is sorbitrate. And the third question is when should we use bacterial lysates? Is it indicated in COPD patients?
We didn't get the question.
Kindly repeat your question, please.
That much only, sir. Thank you.
Kindly repeat your third question.
Okay.
Pardon?
Kindly repeat your third question.
When should we use bacterial lysates like immunomodulators?
There is no role of immunomodulators in the treatment of COPD. I have just discussed
it. Is it indicated in COPD patients?
It is not indicated. Use of short-acting anticholinergics are only in acute exacerbations of COPD. Long-acting anticholinergics can be used from mild COPD onwards on any stage of COPD. Mild, moderate, severe and very severe, in all of them they would have a role. From moderate onwards, usually in mild and short-acting beta-2 agonists would be good enough. And the last question was? Okay. Okay, now the effect of sleep, in which the first effect of hypoxia is usually seen in sleep, and the effect of hypoxia in sleep is seen earlier than in maximal exercise. These days air travel is very common. Okay, now I believe
we are running short of time. We will discuss it further in our third session, which will be held at from 4:30 p.m. on same channel in same program. Till then, keep watching your own channel.